3D treatment planning procedure. And so this is the portion that is importing CTs and creating structure sets. So this gives a nice little overview of the entire process, moving from the top left to the bottom right. This is the process of importing CTs and creating structure sets, the basic workflow. So you start with a 3D image set from the CT simulator, which is then imported into the planning system. And then there's some preparation work that happens prior to the planning, which includes defining a volume for dose calculation, importing any other diagnostic 3D image sets that will be used for contouring, for any other information that is incorporated into the planning, an image fusion between the 3D image set from the CT simulator for planning, the planning CT, and those other 3D image sets, which are imported, and then define the target and organs at risk, and then finally defining the isocenter and the relationship with the setup at CT simulation. And after that, you move on with the treatment planning. So we'll go into detail on each of these steps and of the process. And one thing to note is that the order of these tasks can vary a little bit from this setup that I have here, particularly where the isocenter is defined can be done actually at the CT simulator in some cases, especially for simpler, more simple cases. And so that may happen very early in the process. When the images are imported, could also happen at different stages. And so this is kind of a general workflow, but the order could vary a little bit. All right, so let's start with the 3D image set from the CT simulator. So this is a picture of a CT simulator, and it has some of the elements that you can expect to see in a CT simulator. It's a little different than a conventional simulator, and then some things are the same as a conventional simulator. So to start with, we have our control room that is here. So the people who are, the technicians who are running the CT are located outside the room. The CT bore, where that is located here. The internal CT lasers, so that's your standard lasers that are internal as you bring the patient in. There's a flat patient support table, which is a little bit different than a standard CT, which typically has kind of a concave shaped table. And then external lasers for marking the origin and isocenter. You can see those here, as opposed to the internal ones. So it's just a little easier to mark the patient position and so on and so forth while they're outside the table. And then a CT contrast injector, which is actually in this image is located behind the CT, but that is for injecting bolus and contrast into the patient during the procedure or right before, timed with the procedure, with the CT. And then here on the right, you can see a water bath for thermoplastic masks, which is something that we would typically use for our immobilization. Yeah, so that's just kind of some of the standard details. And, often this may be a CT that is shared with radiology, and sometimes it's dedicated to radiation oncology. If it's shared, then sometimes the table can be, placed on just for the simulation CT and then removed for the diagnostic scans. There may be some, whether or not external lasers are available or not can change, so on and so forth. All right, so a couple of details about that 3D image set from the CT simulator. When we take that CT, in some cases, multiple CT sets may be acquired during the simulation session, but one of these will need to be designated as the planning CT. And what we mean by the planning CT is it's the CT or the 3D image set that is used to define the target and organs of interest, the dose calculation, and the reference image for the image guidance. And really, what really defines the planning CT are these second and third points here, the dose calculation and the reference image for the image guidance. We may use other diagnostic image sets to help with defining the target and the organs of interest. One example would be like a 4D CT in the MIP or an MRI that might be imported to help define the targets and the organs of interest. Although in many cases, it's just very simple. We have a single CT that's imported and is used for all of these purposes, and that would be our planning CT. In fact, I would say maybe most of our cases, that's how we do it. Some important aspects that are important for radiation oncology, and maybe not as important for a diagnostic CT set, is that we have accurate Hounsfield units, and that the patient geometry is the same as the treatment delivery. So some best practices to keep in mind when we're doing a CT simulation: keep it simple. Okay. Moving on to so there's best practices for treatment planning. So keep it simple. It's a good practice to just create and use a small and simple subset of RT-specific CT protocols. Don't change the KVP from those. That helps keep the HU values consistent. Make sure that the gantry tilt is set to 0 for all planning CTs. So a lot of CTs have the ability to tilt the gantry of the CT, but that's really not something that we use in radiation oncology, and it can confound the geometry of the image set. And so we will keep that at 0 for all of our planning CTs and make sure it's 0 when we take it. And then just beware of the... Yes.
It looks like there is a question. Ben asked if everyone understands what planning CT means, and some folks would like you to clarify, please, what you mean by planning CT.
Sure. So when we go to our planning, an image set that defines the Hounsfield units for every location and is used to calculate our dose, and also the location of the patient and all those things at the treatment. And so that's kind of on this bottom right. And so we have to choose a single CT to define that geometry and the Hounsfield units for dose calculation. And so even if we take multiple image sets, so you can see on the top left, we have one image that was acquired at CT, and then maybe some other diagnostic images on the bottom left. And those are fused in the planning system. So we have all that information in the planning system. We still have to define one of those that's going to be used for dose calculation. And that's going to be our planning CT.
And typically at a department, it's the same CT, right? You commission it. That's the CT simulator that's the CT machine that you're going to use for your planning, right? You cannot go tomorrow and use one from diagnostics, for example, or call it planning CT, correct?
Yeah, and when I say planning CT, I mean the image set itself that's acquired is the planning CT. And then we also have a CT simulator, which is shown here, which is a dedicated CT scanner that would be used. So there's the dedicated CT scanner, and then there's also the image set for each patient that is used as the quote unquote planning CT. It's really it's an image set for that one patient. And that should be acquired on some specific CT simulator, whether that's a shared CT with radiology, or whether that's a dedicated CT scanner in radiation oncology, that's a CT simulator. Either way can work, but if it is shared, then there's some specific things that should be done, specific like physics QA that should be done that's specific to radiation oncology on that scanner, so that it's good to use for acquiring that planning CT.
Yes, and Ben is just stressing on the point that when you draw your contours, you ultimately draw them on your primary image, which is your planning CT, correct? And it's not one slide, it's not one cut, it's multiple slides, correct?
That's right. It should be associated with the planning CT. So it should be associated with it. But you can still use other image sets to kind of inform where those contours are and in that contouring process. But in the end, it'll be associated with the planning CT. So yeah, we just had talked a little bit about this. So for CT Simulator QA, it's possible to tilt the gantry. It's not used for CT simulation, so we set that to 0. And one thing you can do is you can put like a mark on the scanner and make sure that it's aligned the same way with the external lasers to verify that the gantry tilt is set to 0. One thing to consider when taking the image set that's going to be used for treatment planning is to watch the field of view. So for instance, if you look at this scan on the left, you can see that the patient's contour has been cut off on the edges here. That may not be a big deal for a radiology, for a diagnostic scan. If you're just looking to see whether this patient has a specific condition or not, it may not matter that area is cut off. But for treatment planning, you need to have that entire information, because we need to know what is the dose going to be, what's the attenuation of the beam through these different areas. And so we need to make sure that we use a large field of view, an extended field of view that's going to not cut off these areas. This would be a big problem if we tried to use the scan on the left for dose calculation. Whereas the one on the right, you can see the entire contour of the patient, so we can get an accurate dose calculation for this patient. So again, just another note about sharing a CT scanner with radiology. They have different priorities, radiology and radiation oncology. Some of the high priorities for radiation oncology is the CT number accuracy and the spatial accuracy, because we need to know that the distances are correct. If we, for instance, if we know our isocenter should be 5 cm to the right or something, we need to know that that's actually 5 cm. Those CT number accuracy and spatial accuracy aren't as important for radiology if you're just looking, again, to diagnose a certain condition, but it is important for radiation oncology. So for that reason, whatever scanner we use for the dose calculation, we need to make sure that radiation oncology specific QA is performed on that CT scanner. All right, so moving on to our next step, which is importing that CT to the treatment planning system. So the way this works is we start with a bunch of individual CT slices, because the way that the CT stores that entire volume set is as a DICOM files, one for each individual CT slice. So you can see those here. On the left, we have a series of CT slices. Usually there's going to be somewhere between like 50 to 300 or something like that. And so you have all these different individual files, and those are exported from the CT scanner to the treatment planning system and then imported. And so the first thing to note there is to make sure that all of them have arrived and that the number of slices that have been received are the same, so they don't end up with either gaps or parts on the top or the bottom that are left off. And then those are then converted into a 3D volume image set by the planning system. So you can see here now, instead of just a bunch of individual slices, you can see it in 3 dimensions because it's been imported and recognized as a 3D volume set by the CT scanner. The next step after that is to convert the Hounsfield units, which is the measure of the intensity in each voxel, into an electron density. And so basically what that's doing is it's telling the planning system what's the relationship between the intensity in each voxel and the density, so that it can calculate dose for a photon or electron beam on that image set, on that 3D image set. So you'll have some conversion from Hounsfield unit to electron density. Now, usually that happens kind of behind the scenes. It's not really something that you do explicitly, but when you commission your planning system, you'll put in some conversion factor, and then it will use that conversion factor. Sometimes it's more apparent than in others, depending on the planning system, but that is a process that has to happen. And so it's good to be aware of that and to know what your conversion is and what your limitations are for that. And all that goes into the commissioning of the treatment planning. Yeah, so the way this usually works, so planning software automatically recognizes tissue density. So the way this works is usually you have, in fact, I think we got an image. Let me just go, here we go. Let's just talk about it here. I will answer this question here in the next 3 slides, and let's move a little bit forward and then we'll answer that. So once you but I'm just gonna do this slide real fast as well. So once you've imported that 3D volume set, all the multiple slices are converted into a volume set, it's good to name that CT in a way that is recognizable. So on the top here, you can see for this patient, this CT has been renamed to have the date that it was taken, and then FB standing for free breathing. And so it's good to have some sort of information, and I think this is a good discussion in each clinic, what information should be included in that CT name. In case patients have multiple courses of radiation or multiple imaging studies, to tell apart what is each set. And so setting that naming convention can be important. All right, so to answer the question about the density, Hounsfield units are related to density. And that's, as you can see here, this is a picture of an early CT, and we use this term Hounsfield unit, but it's really kind of a ratio times 1,000 of what the density or what the attenuation is relative to water. And so that then has a relationship with, so this is really related to attenuation, but then that can be related to density. So here you can see a plot for this phantom, which has all these different inserts that have different densities. And you can see on the x-axis is relative electron density, and on the y-axis is CT number. So for your specific scanner and for a specific set of radiation oncology protocols, you can measure this with this phantom. And this is the information that is put into the planning system. And now your planning system may already have a default, but it's really a good idea to measure this on your own for whatever CT you're using for your CT simulations. And once you measure this, you put this information, basically this curve, in. And so then for any new patient that comes in, the planning system then knows, okay, if I get this CT number, I know it's this electron density, and then it can use that information for the treatment planning, for the dose calculation, I mean. So this is key information for dose calculation. And it's something that can happen behind the scenes, but it's a step that happens for every patient. And it's good to be aware of what information is being used for this, what your limitations are in that, and uncertainties are, and so on and so forth.
So I think it's also important to point out that electron density is not physical density. So the CT number is related to the physical density, right, of the material through the attenuation. But she says the question I think is asking about tissue density, which is related to the Hounsfield unit or CT number, correct? But you're comparing
and the planning system will have, this is a plot from our planning system, and you can see there, this is a relative density. So it's, you can look up in your, so this is electron density plot here. And so our planning system, it asks for electron density for that calculation. So we have a relationship between Hounsfield unit and relative electron density. And so, which is different than physical density, slightly different, but it is different. And so you should know what your planning system is asking for. Is it asking for physical density, or more likely it's asking for relative electron density? And then you put that relationship in, which is going to look something like this. And if you get a phantom like this, the phantoms that I've seen, they will tell you the physical density for each of these plugs, and they will tell you the electron density for each of these plugs. So you should be able to have a plot for relative electron density or for physical density versus Hounsfield unit, and use that information accordingly. And it's good to make sure you know which one you need to input to the planning system and which one you have, so when you measure it. All right, yeah, again, this is the plot there. So you can see here, this is the relative electron density versus Hounsfield units. And for just, this is what's input into our planning system, but it may be different for each, you know, depends on your scanner really. And so this should be measured for each of your scanners.
And sorry, just also to stress on that, and for a given KVP in your scanner, right?
Yes. Yeah. So that's a good reason to keep your KVP constant, is so that you, so that when you measure it, the next time you come and you have a new patient, that you're not unintentionally changing that relationship by changing KVP. So that's a good reason to keep it constant. Or if you use multiples, then just to make sure that that you measure it for whichever ones you're going to use, whichever protocols you're going to use. All right, so to the next step is to define the volume for dose calculation. So you can see here on the left, this is our raw CT for one patient. And you can see the patient's contour, you can see the immobilization device, which is an alpha cradle or a body fix, and then you can see the table down here. Now, one thing to note is that this table, while it's flat, this whole portion below has a relatively high density and is not going to be present when the patient is going to be treated on the linear accelerator. So because of this, this is not really representative of the geometry that we need for dose calculation and for the actual treatment. So because of this, what we would do is we define 3D contour that incorporates the patient's geometry, the patient anatomy, and that can be called, the body contour or the external contour or the outer contour, depending on the planning system. And basically that defines what area should be used for dose calculation. And then everything outside of that can be ignored. So on the right, you can see in red, this is incorporating the contour of the body that's going to be used for dose calculation. Now, this has removed a couple things that should be noted. First off, it's removed the alpha cradle or body fix device, the immobilization device. And it's also, it doesn't incorporate the couch. So the couch, as you can see, is reincorporated back as a model. That's this pink or purple modeled couch that is put in below the patient. And so that can be put in manually after the fact. And planning systems will usually have some sort of a model for that you can use, or you can define yourself to model the patient, the treatment couch that's going to be in place on the linear accelerator. As for the body fix, while that's not incorporated, we do have, it's a good idea to measure for some patients and know what your difference is going to be what's the effect going to be for skin dose and in your attenuation. And usually what we do is we use something we know that the difference in attenuation and in skin dose is going to be small enough that we can ignore it, and then we just exclude it from our body contour. In some cases, we may have an immobilization device that's not the case, and maybe there is some significant attenuation. And in those cases, those devices should be incorporated into that body or external contour. And then there's a question about the artifacts from the BBs. So that's a good question. So one thing to note is that there's different types of BBs, and some of them, that there are specific ones that are made to not cause very big artifacts in CT images. And then there's others that are maybe a little bit stronger and they may be more visible for MV imaging. So I would say, so there's two issues with BBs and the artifacts caused by those. The first issue is that it may obscure some of the anatomy if you're trying to do contouring. And the other is that it may mess up the Hounsfield units for the dose calculation. So for the first of those, I think the best thing to do is use a BB that doesn't cause artifacts on CT. So it's not, usually those aren't going to be metal BBs. They're going to be maybe like a plastic or something that's not as dense as like a metal BB. Or, and then as far as the dose calculation goes, if it's causing an issue with the, usually the BBs are pretty small, so they don't cause that big of an issue for dose calculation. But if that is a concern, what you could do is you could contour out an area around that, and then you assign the density. So usually the planning system has the ability that you can assign a density for a structure. And so you could just assign it to a water equivalent density for the area around that, so that you don't have artifacts in the densities.
And following up on this point also, if you have a metal, high metal, like sometimes with the prosthesis, you also contour these and a density and an electron density given by the manufacturer, correct? Even if
yeah, absolutely. So there are certain, when you have metal that like prosthesis or other metal that's been in from a surgery, it's a good idea to contour those and around those, and either just and then to assign a density to those. And usually, I don't know if I have a slide on that or not. I don't think so, because it's really part of the planning process. But it's a good idea to avoid your beams going through that but like entering through some high density implant to get to your PTB. If it's exiting through it, it's not as big of a deal. But if you're entering through it, then that can cause a lot of uncertainty at your target volume. And so we want to avoid that. So we usually try to avoid entering through like a hip prosthesis or something, and when we're treating dose beyond it. So we're going to move on to the image fusion next. Yeah, and metal artifact reduction. There's a good question about metal artifact reduction. Yes, you can use metal artifact reduction. One thing to note is that those, a lot of those algorithms are iterative, and they can have some limitations. So you should look up the metal artifact reduction algorithm, and often they'll tell you, don't use this if the metal is next to air or low density or something like that. So you should just be sure that you're aware of the limitations of the metal artifact reduction, but certainly can be very useful to deal with those. And it may be a good idea to reconstruct with and without the metal artifact reduction algorithm, just to make sure that there's no funny changes to the anatomy based on that reduction. And then once you review it, then just use the metal artifact reduction version.
Justus, another question.
Yes.
Why can't we use MRI for planning?
So I think the question was MAR, which is metal artifact reduction, which is fine.
Sorry, because I said Muhammad, do you mean MRI? And then Muhammad said yes, thanks. I'm not sure actually.
Okay. As far as using MRI goes, that's another good question. So CT is very useful because the Hounsfield unit is related to attenuation, which has a very direct relationship with electron density, which is what we need for dose calculation. There are studies, and in some cases, in certain cases, we can use MRI for the dose calculation. But the trick there is that the relationship between the intensity and the electron density is not straightforward. And so usually you have to identify what the organs are and then assign a dose, a density to those. And so that just adds a level of uncertainty for the dose calculation. Now, for something like a brain or something where you don't have large heterogeneities, that may be just fine. But it's certainly something to keep in mind is that if you're going to do that sort of a process, usually it's going to be something very specific. For instance, I think Gamma Knife uses an MRI for dose calculation, but really you've got to make some assumptions, and you have a little bit more uncertainty built into your relationship between your planning set intensity and your physical density. And that's not, you can't really just have a single plot like this that's going to define that. It's going to be really you define your organs, and then you assign your densities after that. All right, so moving on to the other diagnostic 3D image sets. So there's many reasons why we may want to import different diagnostic image sets to help with the planning process. And some of the purposes of those include target definition, quantifying progression and differentiate new from previous treated areas, and then motion management. These image sets are then imported to the planning system, and they're fused with the planning CT. And then they are not used for dose calculation, because we're just going to use one set, which is usually, it's going to be this planning CT. And so we don't need to define a body contour for those, a body structure to convert intensity to electron density. We're just going to use it. Usually, it's just going to be fused to the planning CT and then used in whatever way we need it. All right, so just a couple notes about 4D CT, which is a very commonly used procedure for motion management, especially for like lung cases or maybe abdominal cases. So basically, what this is we define at CT the breathing signal. You can see on the right here, this plot where you can see the patient's breathing. And that can be monitored in a number of ways, either with a bellows or with something like this. This is an ABC system. On the left, active breathing control, or on the right, there's like a marker box with reflective markers placed on the patient's chest. And then what that does is you basically acquire projection images are acquired throughout the scan, and they're correlated with that breathing signal. And then you reconstruct basically 10 different CT scans, each one representing a different segment of the breathing signal. So you can see on the left, this is what we call the 4D CT, which is acquired during the simulation session. And it has 10 full volumetric spectric CT scans, all acquired simultaneously, and each is a phase of the breathing signal. And this can be used to assess the extent of target or organ at risk motion. So if we're looking, let's say in this area, we can see, okay, how much motion is, we can quantify it. It looks like it's about 1 centimeter or whatever. And then often this will be used to decide what should we do, if anything, to manage that motion. Other images can be derived from this 4D CT. This includes an average CT, which is basically each voxel is the average Hounsfield unit from all 10 of the 4D CTs. So here on the left, we have 10 different CTs. If you just take the average at any time, or of all of those 10 phases, you end up with this one here. And this is appropriate for planning and dose calculation, because now each of these is going to be representative of the intensity during treatment planning, or during the treatment delivery. And so we can use this for planning or for dose calculation if we want. The next one here is the maximum intensity projection image. And so in this case, each voxel is the maximum Hounsfield unit from all 10 phases of the 4D CT. Now this one we can't really use for dose calculation, because we've taken, basically of these 10 phases, we've taken the maximum. So it's really going to over-represent the density, because we're basically taking the max at any time. So we can't really use it for dose calculation because it's not representative of the intensity over time. However, this is used very commonly to capture the extent of the motion. So especially for something where you have a target that is more dense than the surrounding tissue, like a lung tumor, what you can do is, by getting the maximum intensity projection, you can define the entire extent, or very close to the entire extent of the motion. And I'll show you an example of that a little bit later. Now, on the far right, this is what we would typically use even in the absence of a 4D CT. This is a free breathing CT. So the free breathing CT is just a normal CT. It's a standard CT taken with the patient breathing freely. And so this can have an extended scan range, because as you can imagine, the dose from the 40 CT is going to be quite a bit higher than a standard CT. So we usually try to minimize the extent of that 40 CT. And then if we need a larger extent of motion or a larger scan range for planning, then we will take that with a free breathing CT rather than with the 40 CT. And this can be appropriate for planning and dose calculation. But there's one note here, is that if we do have large, like respiratory motion, that motion may not, the free breathing CT may not include the extent of the respiratory motion. So it's better to use a MIP, this maximum intensity projection image, to define the target if it's available. So here's an example you can see. So on the left, this is a standard free breathing CT, and you can see the motion, or you can see the target there. And as you can imagine, each slice of this is really just a snapshot of the patient at one time point. For the 40 CT, we have 10 different phases, and you can see here, this one in the middle is the average of that 40 CT. So now you can see the extent of that motion a little bit better, but the edges are a little bit blurred out because sometimes the tumor is there, sometimes it isn't. So it gives you a good representation of what the density is over time, but it can be difficult to define the target volume because it's going to blur out depending on how long the target is in each location. On the right, this is the maximum intensity projection image from the 40 CT, and here you can see the tumor looks a lot larger than the two on the left, because if the tumor was there at any point during the 40 CT, it's going to show up as a high density. And so we can contour this and define our tumor to include the extent of all the motion using this maximum intensity projection image. It's very good about that. Of course, we wouldn't want to calculate dose using this scan because it's going to overrepresent the density over time. So what if the respiratory motion is really, really large, and maybe and we decide it's too large to treat free breathing? There's a lot of different things we can do. We can ask the patient to hold their breath. This is going to require some sort of technology at the machine and at the simulation CT to measure and quantify the breath hold to make sure it's consistent. And if we have some sort of technology, then we can ask the patient to hold their breath during the simulation CT. We can record the magnitude of the breath hold, and then we can repeat it and make sure it's within where it's at the same magnitude as the simulation within a threshold during the treatment delivery. Another option is abdominal compression. This shows an example of that, where you basically use some device to push on the abdomen and try to basically help suppress any respiratory motion for the patient. And there's different studies saying, whether or not this is very effective or not. And I think it's a good question. But basically, it may just help to limit the respiratory motion. And in that case, it could be used at simulation and the treatment to be able to treat the patient free breathing, but with this abdominal compression in place to limit how much volume has to be treated. And then the final option also includes some sort of specialized hardware, which is gating, where basically you choose specific phases of the 40 CT to treat on. And then in that case, you would use specific phases for defining your volume, for dose calculation, and then for treatment as well, and gate the beam and only turn the beam on during those specific phases. And so this is a very complicated technique, but it's an option that's out there and you may hear about to limit the motion and the extent of the volume that's treated. All right, so we've talked about different diagnostic sets. Once those are imported to the planning system, we have our planning CT and we have our other diagnostic images, and we need to fuse those in the planning system. So one volume image set is used for planning, we need to define the spatial relationship between each volumetric image set. Now, it's possible to do this without defining this. So, for instance, let's say you have an image set that you didn't even import to the planning system, and you can kind of consult that while looking at your planning CT. You import it to the planning CT, and then you fuse an MRI and a planning CT, and they're fused so that we have, to the best of our ability, we've defined the spatial relationship between them so that each voxel is, for the most part, lined up. So typically, image fusion is carried out by the medical physicist and reviewed by the physicist and potentially the radiation oncologist as well. And this can be called image registration or image fusion. Yes.
A question from Contra. She's asking, is this technique, meaning gating, is for lung cancer patients? If it is the case, sometimes it's really hard for them to control their breath.
So gating is not, you're not asking them to control their breath. You're having them breathe normally, and you're just monitoring the breathing cycle. And as long as the breathing cycle is regular, then you choose specific phases of the cycle that the beam is on. So the beam will be on while they're usually in exhale, and then it turns off while they inhale, and then you wait till the next exhale to turn the beam on again. So and it would typically be used for something like a lung patient, but could also be used for like a liver patient or something like that. And I mean, it should just be noted that this is something that's specialized and requires extra hardware, but it's just, you know, it's certainly not something that I would recommend for starting off. It's just good to know that it's out there. And I think once you have kind of comfortable familiarity with kind of the whole process, can be something to be looked at potentially, but requires some specialized software to be able to gate that beam while monitoring the breathing cycle. So there's different types of image that can be performed. This includes a rigid three-dimensional, where we only change the translation, left, right, anterior, posterior, superior. So as you can see on the image on the right, so right now it's doing kind of a translation, but then there's also a rotation. Rotation would not root it in a rigid three-dimensional image fusion. A rigid six-dimensional image fusion includes the rotation and can include it in each dimension. So dimensional is what we would typically do for image guidance at the machine, where we can't really change the rotation except for maybe in one dimension where the couch angle. A six-dimensional rigid dimensional is what we would typically use when we're fusing different image sets in the planning system, because we can basically rotate that and translate that as much as we want to get the best type of match. Another type of image fusion is deformable image registration. This is, so often a rigid registration can't accurately match all areas of the image. So for instance, this spine case you can see on the right actually matches pretty well, but you could imagine if the patient had the curvature of their spine a little bit different, then you could see a situation where maybe the upper spine you could get to match, but if you match the upper spine, the lower spine would be way off. Or vice versa. You could match the lower spine, but the upper spine would be way off. So in those cases, and another good example is for a head and neck case, if the neck was different during the CT and a diagnostic scan, or if the patient was lying on a curved surface as opposed to a flat surface. In those cases, it's possible to use what's called a deformable registration, so that the spatial relationship can be deformed to match all areas of the volumetric scan. And we'll talk a little bit about that a little bit later, but I'm going to leave it to the side for a second. All right, so the other thing is that how this registration is carried out can be done manually or automatically. Manual registration is when the user iteratively adjusts the position to find the best match between images. This is often performed after an automatic registration to find the result. So for instance, on this image on the right, basically it's the user can, use the arrows or the mouse or whatever and kind of move the image manually to get the match. And that's what a manual registration is. So as a best practice, it's good to focus on an area of interest where the PTB is, to match easily identifiable structures, and to be sure to check the agreement in all three dimensions. So for instance, you may get a great match in one dimension, but then you go to the next dimension and you find that you're off by a lot. So it's good to check all three, and once you have something you like, to verify in all three dimensions. Another type of method of registering is point or feature-based registration. So in this case, you select points on each image of identifiable features. So for instance, you may match a specific point on the vertebral body here, here, and here. Then the planning system will calculate the rigid registration to best align the selected points. And you need at least 3 points defined. A variation of this method is to use the delineated contours in place of points, and then you match those, and then those contours are matched. I would say this is not as common of a method, but it is a method that's out there to be aware of, and may be an option on your planning. And then intensity-based registration, where this is kind of an automatic-based registration, where you compare the intensity values in each image set, apply a region of interest in the area of the target, and then a similarity measure is calculated between the pixel, and the registration is iteratively modified to maximize similarity or minimize dissimilarity, depending on the algorithm. So basically, usually you define some area that you're interested in, and then the planning system will iteratively change it to get the best agreement. So there's different types of similarity measures. This is maybe a little too much detail, but I think I have one of the questions on it, so I left it in here. One option is sum of squared difference. So basically take the raw difference between intensity values. This is not typically used clinically. It's appropriate when the intensity values should match perfectly, like a CT to CT with the same scan settings, but it's not very robust. Cross-correlation is similar. This is great at comparing intensity volumes with image volumes with intensity values that are correlated, but that do not match absolutely, such as matching a CT to another CT or to a cone beam CT. But it doesn't work well, for instance, when there's not that kind of correlation. Like, for instance, if you try to match images for different modalities. Then mutual information quantifies the amount of information obtained about one random variable through observing the other random variable. It's related to entropy. This is great at comparing image volumes with dissimilar intensity values. So like, for instance, an MRI compared to a CT. It's most robust and most common similarity measure that's used clinically.
Gasm is asking, are these types of registrations dependent on the TPS that you use?
Yeah, so usually your planning system will have probably something built in. They may not even tell you what they're using. And then other planning systems, you may be able to choose between these. So for instance, if you can't really see it, what it's using, it's probably going to use mutual information. But if it does give you the option, then one thing to just keep in mind is that cross correlation works great for if the intensity values should be kind of linearly correlated or just basically correlated. And mutual information is great to use if you're going across different modalities. But if you don't see an option in your planning system, it's probably behind the scenes and it's probably using mutual information. But it's always good to verify your results to make sure that it's, giving something that's close. All right, so just back to deformable registration for a minute. And I just want to caution that deformable registration, it's not typically used clinically. We kind of avoided it when we can because there's just a lot of questions. It's difficult to know what the uncertainties are behind when you use it in a clinical situation. So many different algorithms exist with varying levels of accuracy. The results from deformable registration are very difficult to verify. Registrations can be prone to errors and not robust to large changes in anatomy. For instance, if you're going from your arms up to arms down, that can, that's a huge deformation. and getting a good result can be, very tedious. And often it's just better to just not even register the images and just consult them independently if you need information from a different set. Rigid registration is what is almost always used clinically. Best practice is to select an appropriate region of interest for rigid registration and ignore the areas that are outside of that if they don't match.
Sometimes you do use deformable registration when in situations where the patient has weight loss, right? For example, so you want to.
Yeah.
Okay.
Yeah, and there may be good situations to use it. It's just you should just be careful about it because often you just don't know what the uncertain. If you're using a deformable registration, usually you want it to be. It's going to work best when that deformation is subtle, like a weight change, as opposed to like some huge change in geometry, like you have arms up to arms down, or even like moving the legs or the like rotation of the head. Those things, when you have a large change, you just have to be a little more careful. And there's a question: can deformable registration be used for adaptive radiation therapy? I think there's research studies that do things like that. Typically, in our clinical practice, we do not use it for adaptive radiation therapy, but it's certainly a potential option. What we do typically is we will just let's say we have a patient who comes in and they have a weight loss or something, or let's say we're going to do some sort of adaptive treatment. We will typically just do the adaptation at a certain point, so maybe like a week or 2 or 3 weeks into treatment, and it'll just be a brand new CT that's rigidly registered with the old planning CT, and then recontoured in a new plan. But there's a lot of different ways that you could go about doing those things, and some of them may include deformable registration. Okay, so moving on, defining target and organs at risk. So now we have a planning CT that's been imported. We've defined the volume for dose calculation. We have other image sets that have been fused to the planning CT. Now we're going to define the target and organs at risk. The volumetric image is different than the structure set, and I think that's something that can be confusing. The volumetric image is the matrix of the voxel intensities that describe a characteristic of the patient, such as the attenuation or the magnetic resonance or whatever it is. In this case, it's attenuation, which shows up is correlated with our electron density. That's what we're seeing with the gray, it's the intensities that we're seeing. The structure set is the target and volumes defined using the volumetric image. So these are what we define to say, here's my liver, here's my PTV, here's my CTV, here's my GT, here's my spinal cord. Where those are, and you can see here these colored contours, that's what we call a structure set. So when we define the target, this is defined by the radiation oncologist, and we follow typically following ICRU and 50 and 62, the physician delineates the gross tumor volume, the clinical tumor volume, and the planning target volume. The PTV is derived from the PTV is defined by the CTV, accounting for localization uncertainties. So the radiation oncologist defines the GTV and the CTV, and then we will define a PTV based on the uncertainties in our planning process. So GTV is the gross visible disease. CTV includes subclinical disease, volume where the disease is expected or at high risk of being present but not visible. The relation between the GTV and the CTV can be straight in some cases, or may not be. It may include nodal areas that are not in the GTV. So you can see in this case, it's not really a straightforward expansion, but for instance, for our case, like our physician for other diseases, it may be appropriate to just add a couple millimeter margin to the GTV to get to your CTV. And then the PTV should depend on the type of immobilization. Accurately, our margin from our CTV to our PTV may be fairly small. But if it's less rigorous immobilization, it may be a larger margin. The other thing that goes is whether there's going to be motion. So if it's in an area where there's lots of respiratory motion, then that CTV to PTV margin may be larger. The one thing I will note about this is that sometimes may not entirely follow this GTV to CTV to PTV definition. If in like some palliative cases or something, there's other ways to do this and still do 3D planning. By the physician, for instance, may define just the field shapes or something like that. But typically, this is what is recommended to do: is define the GTV, the CTV, and the PTV. So defining the organ risk, this can be defined by the dosimetrist, the medical physicist, or the radiologist, depending on the institutional practice, expertise, and critical importance of the organ at risk. So for instance, something that is really, really close to the PTV, like if this, for instance, if we're treating the spine and the spinal cord is right next to the PTV, we may ask the radiation oncologist to, at minimum, review those contours and maybe potentially even just make the contours themselves. Whereas things that may be farther away, that may fall to the physicist. Best practice, define a standardized set of structures that are contoured for each treatment site. So if an organ at risk is in the CT, it's really far from the target. It's always going to be far from the target for that potential target or that potential treatment site. Then we may not define it. And what we'll do is we'll say, okay, for this treatment site, we are always going to be concerned with these 5 structures. So those are the 5 structures we're going to contour every time. And ones that are always far away, even if it might be in my planning CT, we won't even contour it because it's not of interest. We're just basically going to be wasting our time by contouring it if it's not going to be important to look at. So, and at the same time, depending on who is doing these contours, we don't want to leave out one that is going to be critical. So it's a good practice for each treatment site to have a list of, for this one, we always define the liver and the kidneys and the bowel or whatever it is, and just always contour those for specific treatment sites. Contouring tools, each planning system has its own set of contouring tools. And they're usually pretty straightforward to use. Those may include manual contouring tools like 2D, 3D brush, smart mesh editors, flood-filled Boolean operators like Atlas, and machine learning-based automatic contouring features depending on the planning system. So there's different options. The colors of these are just to determine different structures. So there's nothing important about the colors besides just making them different so that you can identify them as different structures. All right, once we've defined our organs at risk, I guess one thing that I didn't have a slide in here, I probably should, is that we may define these organs at risk or the PTV based on MRI or some other diagnostic image that it would be associated, those structures should be associated with the planning CT. And if I go up here, you can kind of see that. Let's see if I can find it. There, here we go. So you can see here, I have a CT, and then I have a structure set, that's this one here, and then I have my different contours. So these contours that are with the structure set, these should be associated with my planning CT. It's possible that they could be associated with another image, but those should be transferred to the planning CT for planning eventually. All right, so isocenter and relationship was set up at CT simulation. So when we do the simulation, the planning CT will have some origin point or 0 point, and you can see that this green cross here, and that where was the 0 point at the CT. And in this case, BBs were placed on the patient and on the immobilization device to define that position. And that can be a good practice to verify that that it's where we expect it to be. The isocenter may or may not be that same point. If it's set at the as possible, we could define the isocenter to be that point. But usually we don't set up our isocenter until after we've imported the CT to the planning system. So in which case the isocenter may be a different point than the origin. In fact, it usually is. So we need to provide instructions for how to move from this point, which is marked on the patient and marked on the immobilization, to our isocenter. So this is an example of one patient that has a setup note. So it has notes in the top here you can see about what type of immobilization is used. And then it also has instructions on what type of where we should shift the patient to get from the origin point to the isocenter. So in this case, its is shift from CT0, 1 cm to the right, going this way, 2.5 cm posterior, and 5.5 cm inferior. So basically, at the first fraction, the therapist would move the patient by that amount and then mark their isocenter. And so that relationship is defined. Sometimes you can define in the at CT, or more commonly, it's defined in the planning system, and then you just provide instructions at the linear accelerator on how to make that shift. And that is all that I have, unless there's any other questions. Thank you very much.
This was great. Is there a difference between CTV and GTV and what? Sorry?
Density. Yes.
So, you want me to answer?
Yeah.
Okay. So GTV is your gross tumor volume, right? It's what the physician can see or feel. And then there's subclinical disease that you see around that GTV. When you expand the volume to include that subclinical, you create a CTV, right? So the GTV is part of the CTV, right? The CTV is basically a tumor volume created to encompass and include what you cannot see. And then to include the uncertainty in the positioning and motion between interfraction and all that, you add an additional margin, and that's your PTV now. So it's not like, I guess it's not that you're looking at the density per se, right? Like your position. Does that make sense?
There may be specific situations where, I mean, if you think about it, GTV, a gross tumor volume, it's what you can really see, right? So it's possible that there may be cases where your GTV may have a higher density or something, and then your CTV, because it's where you suspect there's disease but you can't see it, that maybe you don't have that high density. But really, the way to think about it is, where can you define the gross tumor volume, and then where is there disease that is expected but maybe not potentially visible? Sometimes that may have a density, a relation with density, but other times it may not.
Yes.
أو يشوفوا على السي تي كده يسميه جي تي في. بس مرات الخلايا المحيطة بالجي تي في ممكن يضيف حدود ويسميها سي تي في clinical target volume. دي اسمها سي تي في اللي هي في الخلايا الثانية. وبعدين البي تي في تتأكد إنك عايش كل المنطقة بتدخل. واضح؟
I think that's better to show the concept of GTV because with the vertebra, we cannot really see the difference between the GTV and CTV, like how come that part was the GTV. Yeah, so I think this gives a clear definition. Is it possible I speak in Arabic, please, Dr. Justus?
Absolutely.
Okay, thank you. Dr. Justus, مثل ما تفضلت فالإكسترا intensity اللي انت تتكلم عنها حضرتك هذا هو الجي تي في هو الورم الملموس. ف this is what we call الجي تي في. بعدين يجي مفهومك انت كطبيب في الاريا.
You know, I would just note that I think the next lecture also is on ICRU and definition of CTV, GTV, CTV, PTV.
Yes.
So I think there's going to be a lot more detail there.
So we will touch. I will be the presenter for the next lecture on formal therapy. ففي مفاهيم لازم نعرفها including GTV, CTV, PTV, including prescription points, including normalization points. On Thursday, please, everyone, if you can log in, and it's better to have everyone logged in so we can have interactive session. And thank you, Dr. Justus, for giving me the time.
Yeah, absolutely.
Thank you, Shada. Okay, there were two questions earlier, and I took a little bit to answer them. But do you have time, or do you need to leave, Justice?
No, that's fine. We can answer them.
Okay. So first question was from Lara, and she was asking, she said in the example that you gave for CT, naming your CT study, you used special techniques like FB and IBH, right? I think yours ended with an FB for free breathing. Her question was, what other techniques can you include in that naming? Like, what other examples of techniques, I guess?
Yeah, I mean, I think it's a good pattern. I mean, other things that I think we've thought about before, number of CT slices, because we had some problems with, if we had CT with too many slices, we were running into some memory issues that at the machine. So, you know, I would just think about what information there would be most useful. It might be you could put your course number, like what course of radiation it's for, or you could put your, you know, which CT scanner it came from. So I think whatever the most important information there to identify that, I think you can think about it and decide what would be best.
And I told her I think it's important to be consistent in a clinic.
Yeah, absolutely. Probably have some sort of set criteria that you always put in, right?
Okay. The second question was from Abdu, and his question was, do you have to use the same, I think his question meant gating window. He said gating, is it the same every day? And I told him, yes, whatever you set at time of planning, that's what you use throughout your treatment, correct?
That's correct. Well, so the gating is really, I mean, at the time of planning, you said it. You don't even need to decide that at the simulation, because you just basically choose some phases, and then you use those phases for planning, and you use those phases for gating the treatment at the same time. The only trick there is with image guidance, how to best set up the patient, not very easily for your cone beam at the machine, or however you're doing your image guidance. So in that case, you have to think about that. Usually you set up to free breathing or something like that, and then treat and gate it. But it's a lot of details there that probably go a little bit scope of just kind of, you know, the basic import for moving from 2D to 3D.
Yes, thank you. This is a comment from someone, but not to you. I think it's more to us. And he's asking us for a summary at the end of each session in Arabic or French. Ben, عايز كل حصة، وعفوا أنا ما عندي كيبورد عربي I cannot type in Arabic. فممكن تجاوب يعني ممكن تكتب إجابة.
It's very good.
Someone said he has a question, right?
Yeah.
Welcome back. I'm sorry?
Can we define isocenter in any point? Is there any effect?
Can you define the isocenter at any point of your choice, or is there a preference? Is that your question?
Yeah, a little bit. That goes to the treatment, I'm sure, like when we discuss treatment planning, but typically you put it in the center of like the PTV. And the only reason not to do that is sometimes, like, let's say you're treating something really far to one side or the other, you may run into some collision issues. So you may want to just be aware of that. And for instance, if you're using arc treatment and you're treating something really far to the side, you may not be able to do a full arc if you're really far to one side or the other. So you may want to put it more central. But I think it's a very standard practice to put it in the center of the PTV. And that way it's always kind of what to expect in all the planners doing it the same, that there's a lot of value in that.
Okay. Laura has another question. She's asking about surface-guided radiation therapy. What is the role in CT, or is the role in it only in the treatment machine? I guess what CT role is there for surface-guided radiotherapy is her question.
It's a good question, actually, and I kind of brushed over it because we don't typically use it here, but it's a very useful tool. The big benefit of surface-guided is that it's non-ionizing, so it's kind of free information. And so usually the way that works is either at the CT or at the first fraction. Usually with surface-guided, you acquire some sort of contour, maybe at the first fraction after you set up, or based on the CT, you get some contour. And then you can verify each day that the contours are aligned, or use that information for your alignment. And so it's kind of, it's a way to do that without any ionizing radiation. And it's a very useful tool to have in place. As far as planning goes, it doesn't really factor too much into the planning process. It's more of the image guidance process at the machine.
Any more questions? Thank you very much, Justus. This was very good.
Yeah, thank you very much.
I'll see you later. Thank you, everyone. Bye-bye.
I think there's a question.
Oh, oops.
Yeah.
Did Justus leave?
No, I'm here. So why is the image in beam view is less accurate than the simulator?
سيف يعني تقصد الصورة في البيم اي فيو مش
أقل وضوحا من
أيوة this is physics principle. So in the simulator you're seeing bone صحيح؟ بالsimulator تشوف العظام أكثر. But the beam eye view is 6 MV. هي تكون
It depends on the density of electron.
No, this is physics principle. So a simulator low KeV, ففي عندك photoelectric. So bone is higher probability of interaction when you have low energy صحيح؟ إذا كل التشوز عندها نفس احتمالية الكومبتنس سواء كان bone ولا كان السيموليتر. ولا يهمك. هلا بيك أخي العزيز.